Welcome everyone, and this is lecture 27 of this series on fluids and electrolytes. The lectures explain, expand, and accompany my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I'm Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. This is the book. It's available on Amazon. I'll provide more information in the description below. If you haven't done so already, please subscribe to the channel. Today, we are still on Chapter 3, Hyperkalemia. We're going to talk about a very important topic, management of hyperkalemia. So please pay attention here. You may be able to save someone's life. So we are going to discuss first treatment of hyperkalemic emergencies, and in the previous lecture we said a hyperkalemic emergency is hyperkalemia associated with EKG changes, peak D waves, prolonged PR interval, absence of P waves, QRS widening, even more serious signs like the sine wave. So EKG changes. Any rapid rise of potassium, like you would see with tumor lysis syndrome or hyperkalemia, for example, oliguric acute kidney injury, or hyperkalemia associated with muscle weakness or paralysis. So if you have any of these things plus hyperkalemia, you have a hyperkalemic emergency. Usually potassium is 6 and above, and we have to focus our treatment on 3 objectives. Number 1, we need to stabilize the myocardium membrane. We need to prevent arrhythmias. Number 2, we need to facilitate cellular uptake of potassium. And finally, we want to get rid of the potassium. We want to eliminate the potassium. And we do these steps in this order: stabilization, shift, and then elimination. Now, patients should be placed in the intensive care unit or on a cardiac monitoring. Needless to say, if the patient is on any oral or intravenous source of potassium, it should be eliminated. So if the IV has potassium, stop that IV. If the patient is on TPN, and usually it has potassium, stop TPN. If the patient is on enteral feeding, and usually that has potassium, even if it's a potassium poor formula, stop the enteral feeding until this is dealt with. If the patient is on potassium chloride, please don't give them that potassium tablet. So this is obvious. First thing we need to do is myocardium membrane stabilization. We need to do that if we have EKG changes. In other words, if you have hyperkalemia and no EKG changes, do not give calcium gluconate. Now, if you do have EKG changes, give 10 ml of 10% solution. This is 1 gram of calcium gluconate intravenously. You don't drip it over 30 minutes or 1 hour like you normally do. You give it over 5 to 10 minutes. This will immediately antagonize the effect of potassium on the myocardial cell membrane, but it doesn't do anything else. It does not shift potassium. It does not eliminate potassium. Therefore, if you don't have EKG changes, it has no benefit. If the patient is on digitalis, is on digoxin, don't do it because there has been several case reports of sudden cardiac death. Now, the onset is immediate and the duration of action is 30 to 60 minutes. You can repeat it if needed. Therefore, if you have a patient with hyperkalemia who is coding, okay, if all of a sudden you have ventricular tachycardia, ventricular fibrillation, you are going to do your ACLS protocol, but also give calcium gluconate. This may help the patient more than anything else. So do not forget calcium gluconate. Oftentimes I see patients going to the emergency room and they don't have EKG changes and they get that anyway. It doesn't hurt, but it doesn't help either. So I'm saying that because, I mean, we have to know what we're doing, right? So first, we stabilize the myocardium with calcium gluconate. The next step is to cause intracellular shift of potassium. Now here we have insulin, we have albuterol, and we have sodium bicarbonate. And it has to be in that order. So with insulin, we give 10 units of regular insulin intravenously. And we need to give dextrose with that to prevent hypoglycemia. So if blood sugar is below 250, we give 1 amp of D50 to prevent hypoglycemia. If blood sugar is already high, if you have a sugar of 300, 400, just give the insulin. You don't need to give the dextrose. Okay, what if blood sugar is 200? Well, maybe give half an amp of D50, so you can use this, use your judgment. The onset of insulin is fast, okay? It works in 15 minutes and it lasts 2 hours, and you can repeat it after that if needed. In patients with chronic kidney disease or end-stage renal disease, there are studies showing that 5 units of intravenous regular insulin is good, because this way you prevent hypoglycemia. So in other words, you have to give insulin intravenously, never subcutaneously, and you give dextrose to prevent hypoglycemia. I have to say it's not enough to give dextrose thinking that dextrose would cause insulin secretion. No, you have to give regular insulin intravenously. After you use your insulin, get your respiratory therapist to give a breathing treatment with albuterol, not 2.5 milligrams, the usual dose. The nebulized treatment here has to be with 10 milligrams, okay? Again, why? Because this beta agonist is going to drive potassium into the cells. We're not interested in giving a breathing treatment just for the sake of doing that. We want to drive potassium intracellularly, so the onset is also fast, about 30 minutes, lasts also about 2 hours. And again, this is higher than the usual dose, so make sure you let them know that this is for hyperkalemia. Okay, so now we've done the calcium gluconate if it's indicated, we've done the insulin, and we've done the albuterol. What's next? Sodium bicarbonate. Consider that, especially if you have metabolic acidosis. And many people use 1 ampule of sodium bicarbonate. This is 50 ml of the 8.4% solution. And it's about 50, it's 50 mol equivalents of sodium bicarbonate. Some give it as a drip. They put 150 mol equivalents of sodium bicarb in 1 liter of D5W, and the rate varies depending on the circumstances. Sodium bicarbonate doesn't really work well if you have someone with end-stage renal disease who is on hemodialysis, for example. So you could probably skip this step altogether. Now, the last thing we need to do is to eliminate the potassium. Okay, so we stabilized the myocardium, we shifted the potassium into the cells, now we need to eliminate it. How do we get rid of potassium? Well, we have 3 possibilities, either through the urine, meaning diuretics, or through the stool, meaning a binder, or via dialysis. Loop diuretics can be utilized to eliminate potassium if you have urine output. If someone is on dialysis and they don't make any urine, obviously there's no point in giving them a loop diuretic. Now, many times we give a loop diuretic and we give intravenous fluids that doesn't have potassium. So in other words, we are giving fluids with no potassium, and we're using a diuretic to get rid of the potassium. And this also will prevent dehydration. Hemodialysis is the definitive treatment. So you have, say, someone with rhabdomyolysis, potassium of 8. You do all that, but you need to prepare them for hemodialysis. It works immediately. Now, dialysis takes time. You need a catheter. You need to call in a dialysis nurse. You need the logistics to prepare the machine. So although it's very effective, it cannot be immediate. So this is why we need to know other steps. Potassium binders can be used in conjunction of the above steps. It should never be the only treatment, okay, because it takes several hours to work at times. So in patients immediately post-op, don't use it. So I want to say one thing. I've noticed over the years that many times the team working on hyperkalemia doesn't understand how urgent it is. So if there is an order to treat hyperkalemia, the calcium gluconate, the insulin, the bicarb, the albuterol, the dialysis, the loop diuretic, it should be carried out immediately. It should be done without any delay. It's totally unacceptable to see someone with hyperkalemia and EKG changes and to give the insulin and glucose 2 hours later because you're busy doing something else. No, this is a super emergency. If it's not done properly, you will end up with a mortality. So I cannot emphasize that enough. Other considerations. So if we have someone who's obstructed, by all means, put a Foley catheter. If you have someone who's dehydrated, give them fluids and maybe a diuretic to get rid of the potassium, like we just said. Low potassium diet is essential, but you are going to do all these things about worrying about what the patient is going to eat, but you need a low potassium diet. You need to discontinue any medications or supplement that has potassium, and we said that. Now you should check potassium every 2 hours until the problem is resolved. Now, if hyperkalemia persists, you just repeat these measures and then you have to do hemodialysis. And note that I'm saying hemodialysis, not peritoneal dialysis, because hemodialysis is a lot faster in removing potassium than peritoneal dialysis. If someone is on peritoneal dialysis, you continue to provide them with peritoneal dialysis. But in emergencies, you really need hemodialysis. What about non-emergent hyperkalemia? So usually these patients have mild and chronic hyperkalemia, maybe potassium 5.7, 5.8. Usually it's less than 6. So here you have time. You can do dietary counseling. You review the medications, the supplements. Sometimes it's helpful to use a diuretic. If GFR is above 30, you can use a thiazide diuretic. Chlorthalidone, for example, is very caldiuretic. If GFR is below 30, you need to use a loop diuretic. If the patient is acidotic, use sodium bicarbonate tablets. Now, in patients with hyperkalemic RTA, such as someone with type 4 RTA due to hyporenemic hypoaldosteronism, it's helpful to give fludrocortisone. The problem is every time I want to give it, the patient has hypertension already. So this agent is very effective in eliminating potassium because you're in actuality giving aldosterone. So it's going to eliminate potassium, but what does aldosterone do? It's going to cause sodium retention and hypertension, and most of these patients already have hypertension and fluid retention. So most of the times I end up not being able to give it, although that would be a very sensible treatment. Low potassium diet, by that we mean 2 grams per 24 hours or 50 milliequivalents per 24 hours or 50 millimoles per 24 hours. You do medications review, you do supplements review. If the patient is on potassium chloride, potassium-containing salt substitutes, potassium gluconate, you stop that. There are many resources to tell you about low potassium diet flyers to give to the patient. I provide here a link on this slide, and I'll provide it also in the description. What about potassium binders? Potassium binders are good for persistent chronic hyperkalemia if diet alone fails. Sometimes you have a strong indication to give an ACE inhibitor or angiotensin receptor blocker like chronic systolic CHF, like diabetic nephropathy, and you cannot get rid of the medicine because you have increased mortality. There's a strong indication. In that case, you give the medicine, you lower the potassium, and then this way you have eliminated the issue of hyperkalemia. We have, fortunately, 2 new potassium binders that are appropriate for chronic use. One is Pitorimor or Veltasa, the other one is sodium zirconium cyclosilicate or Lokelma, and they are very good for chronic use. The old KEliminate sodium polystyrene sulfonate probably should not be used unless you don't have the other binders. Again, binders should not be used for the emergency treatment. They can be part of the treatment, but definitely not the sole treatment. Now, chapter 4 of our book is going to be on potassium binders, so stay tuned. Future lectures will contain much more information on all 3 binders. Final key points on hyperkalemia. Hyperkalemia is common in inpatients and outpatients. It is associated with increased mortality. Symptoms nonspecific, usually musculoskeletal, but pay attention to cardiac abnormalities, to arrhythmias. You can make the diagnosis easily with a simple lab. Do an EKG if potassium is over 6. Hemodialysis is the most effective treatment, and new binders are available and appropriate. Now, I have to leave you again with a final thought. If you get someone with a hyperkalemic emergency, act fast, okay? Don't do the measures we talked about over 4 to 5 hours. You have to do it immediately. If you do so, you may save someone's life. I will see you in the next lecture. We are going to do some cases on hyperkalemia. See you then.